First, congratulations for the symposium so far. It's been a nice mix of information. I think we're all able to kind of synthesize, and somehow or another we're complementary of each other, and many of us have never met, so that actually works out pretty good too. So, I'm just going to talk a little bit today about moya moya. And most people are going to say moya moya disease, and then when the hair on the back of my neck stands up because I hate saying moya moya disease when a lot of it's moya moya syndrome and disease and syndrome. We'll get into the differences there. So I tend to just call it phenomenon, and then I start off with my feeling that I actually hate the word moya moya, right? So that instills a lot of confidence in everybody as I'm talking about it, right? But we'll get into just objectives in general. Risks, etiologies, presentations, a lot of neurological examination, a lot of just like the fistula, which I think I've been harping on a little bit today. Being aware is important. Just thinking about it, knowing it exists, makes a big difference in when patients are diagnosed and when patients get treated. We'll talk a little bit about imaging, which I think has been, again, coming from the stroke discussion we just had. And then really talking about how we best manage stroke risk. This is not a very standardized treatment within practices, within regions. People have different ideas, but really just understanding that the disease and the findings exist is important. So 1957 is when we started using this term. It's a Japanese term that means puff of smoke. And I think if you put an equal to that, it just means bad angiogram, right? Because in 1957, that's pretty much what you have is a crappy angiogram. So you get a crappy picture, you say puff of smoke, and then moya moya. And that's why I hate it, right? Okay. But it is a progressive stenosis of the intracranial vessels. So anything basically distal to the ophthalmic, right? For some reason or another, everything once you get in, you never see it in the basilar, right? And you never see it proximal to the ophthalmic. It's usually not there. If it is, what's going on? But that it happens so slowly that the brain is able to compensate, tries to compensate, and bring other blood flow. Okay, and as I mentioned, if you see moya moya and posterior circulation disease, you should be thinking something else. Okay. These are different examples of patients I've had. This is normal here. You can't see my arrow, correct? So that's normal, but then you start to see things change, right? You start to see things change. There's the ophthalmic artery, and all of this is your puff of smoke. And that's a pretty good angiogram because you can see it. Okay, I'll show you a bad one in a minute. But this patient actually was. I still remember her pretty much. She was one of 35 documented cases of something called alpha-1 antitrypsin deficiency, and she was that was called moya moya, right? But I just told you if it's look at this. Even though this is normal, that's still pretty wide open. But because she had a lot of vascularity up here, she was going on with moya moya until she was diagnosed. And until she died, she traveled the world to visit because she knew she had until 35, right? So she traveled the world to visit other people with this deficiency, which mimics. And I think Rachel will talk about mimics afterwards, right? So, so syndrome versus disease. That's the first thing to, it's kind of nitpicky, but it makes a difference. If you're diseased and you are a 35-year-old, Caucasian male, probably wouldn't be talking about disease, right? Classically speaking, for some reason or another, there's an Asian predilection to patients and diseases in a kid. Okay, syndrome means you've got other things going on that give you the vessel changes that look like the bad angiogram. Right, but it doesn't. But you're not 5. You're not 3. You're not having these. And so other conditions, we get a lot of patients with type 1 diabetes, right? Hyperlipidemia and young and one way or the other Hispanic patients. It happens. Sickle cell disease we see a lot. Okay, Down syndrome, another syndrome that affects and you get similar vessel findings, but none of those are the same. Okay, but the vessels look the same. And then known chronic comorbidities. A lot of moya moya terminology in the chart is related to young patients with accelerated atherosclerotic changes. Okay, again, nothing is 100%, but if you, again, and you get a middle-aged person with their first presentation with moya moya, okay, what else is going on? Look at other medical comorbidities and see what we can figure things out before we just kind of throw that diagnosis on them. It's important. It's not just in those of Asian heritage, but it does tend to peak the disease, okay, at children at 5 years, adults 40s, right? Probably maybe a little bit younger in some of the population that we see, but there is a female predominance. Outside of sickle cell patients, if I just go back in the patients that I've seen, I can probably think of 4 or 5 males who have been symptomatic presentations. It's a pretty strong female predilection. But this is more, world numbers, and in Japanese children where it was noted, and I'll get into some other demographics. But there's a good paper by some friends of mine at University of Washington St. Louis that talked about a North American variant. Okay, here in Texas, us in Dallas probably see more sickle cell, more patients of Hispanic heritage, right, than I will see. I have, in terms of presentation, I'm counting, and I haven't made it to 2 hands, that I've seen a ruptured moya moya presentation, or hemorrhagic moya moya presentation in a non-Asian patient, and 5 of those have been from either came from or first generation here, right? So there's, and this discussion of a North American variant, I think, is very germane, but we're still trying to figure that part out. Are y'all getting? Am I dropping in and out a little bit? So okay, I'll pull it up. So how do they present? Okay, in general, moya moya patients, now I'm screaming at you, but present with some sort of ischemic symptom, TIAs, stroke, seizures, but seizures more, usually something else has been going on for a while before they show up with the seizures. Most of this is an effect of compensation. The headache part, the hemorrhage, our theory behind the hemorrhage is a couple. One, the compensation that's required from the small vessels, which are noted in here as the MCA, which you can't see it continuous from there to there, are not compensating well enough, or too much is being asked of them, so a hemorrhage occurs. 1, okay. Hemorrhagic conversion of prior infarcts. 2, all right, would be probably your main piece. In the sickle cell population that we see, a lot of times people know that sickle cell patients have pain crises, have headaches, have pain. So a lot of people just attribute that to, though, this is just that sickle cell guy coming in with his pain. But when they look at his vessels and they realize that he's trying to dilate every possible channel to get blood flow around these narrowings, all right, there's a potential reason for headache there, all right? And we see that when we do things like middle meningeal artery embolizations and we inject, and the meninges in the patients are awake, they feel it, right? So imagine all those blood vessels are dilated and trying to get blood flow to your brain. As I mentioned, the Asian adult hemorrhage rate is almost half, right? So there's a difference there somehow, whereas the U.S. patients are more commonly presenting with ischemia. Other symptoms that you see, sorry for the typo, it's a cis, X, not an I, but dilated meningeal vessels we talked about, stretch that dura, there's a headache component to that. Refractory migraines, again, all migraines aren't headaches, or all headaches are migraines, etc. But some of this may even persist after revascularization, but some of that's just those shunts that we talked about with the fistula, those other channels that have been opened up. There's a sign that I can't tell you the last time, well, I brought out an ophthalmoscope last week, but it doesn't happen much. But if you look in, there's this morning glory disc that sometimes the ophthalmologists come up with, and I thought it was an interesting corollary to kind of look at the difference between a morning glory and this is the eye findings, right? So sometimes we'll even get patients with ischemic symptoms from retinal or optic that come our way. And again, it's typically associated with frontal parietal temporal lobes. Remember that posterior circulation does not get involved. Okay, so because of that, hemiparesis, aphasias at times not as common in terms of what I see, but the progressive cognitive impairment is something that we just don't catch in patients who are a little bit older, right? And we joke, once you get to know, you get dumber and dumber, something's going on, right? But the seizures, the visual deficits, the personality changes, that those frontal lobes are really getting most of the effect. But it really creeps up until we see changes. I think probably the one that has hit me the most recently was the daughter of my daughter's friend. I'm sorry, the sister of my daughter's friend is at school, and she's having, we see each other at school events and things like that, and she can't see stuff on the left. Right, and we look up, and they call, and she came from Texas Tech with her first diagnosis of moya moya. So now I've got a family that I know and a daughter I have to just treat, and then they're worried about my daughter's friend. Right, so there's all this stuff going on, but it can creep up on you. The one thing that stood out to them that no one thought about, which is I think a pretty significant primary care catch in a young person, people think about a female with high blood pressure and fibromuscular dysplasia or something like that. But if your vessels are shutting down, your blood pressure is going to go up, right? But no one looks at the head. No one looks at the neck usually. They're looking at kidneys. They're looking at, but in this patient who was of Taiwanese descent, right, with blood pressure needing to be on meds in her late teens, right, and she was already pretty much a little bit later stage. So here's your bad angiogram, and I'm sorry about that, but this is an example of some of the changes. This is a small aneurysm that we can sometimes see off of those lenticular striate vessels that are trying to dilate to give more blood flow. And if you think about it, I kind of akin it to sandblasting, right? You've got blood flow just trying to get there. Those blood vessels aren't well developed, and you get small aneurysms. So the hemorrhages that we see are typically deeper, or basal ganglia hemorrhage or something like that. But sometimes you can catch, and this is an example of that. So again, associated conditions. We'll see patients. We talked about syndromes, but another thing we'll see some of the vasculopathies that people will call moya moya. Again, it's the picture would be young patients, young kids who've gotten radiation. Right, so they had radiation when they were kids. They weren't moya moya disease because they were kids, but they had a cancer. So they got radiation and arteriopathy, and now we're seeing symptoms which are very similar. Okay, all that stuff goes into this one term, which again is why it's interesting to use. So the pathophysiology, and once you pull that together, one of the things we don't know as much. The reason we don't know as much about moya moya is because it's hard to biopsy where this disease occurs. Right, you're starting to see some newer attempts at using endovascular brush biopsy, so we can take catheters and stents, these stent retrievers we use for stroke, but you go up there, you detach them, you can actually get cells, and some people are gene typing some of the cells to understand. But there's a mixture of smooth muscle hyperplasia and vessel thrombus that kind of concentrically narrow. And that's one of the things sometimes you can see on imaging is that the concentric narrowing is maybe more of an inflammatory, more of a moya moya type problem, whereas the eccentric may be a little bit more similar to atherosclerotic disease plaque, right? So, and we can see that on some of the special sequences we look at. This is an example of a vessel with some thrombus in it, okay? But this more that hyperplasia of the tissue, which does like that, all right, as opposed to plaque that comes in from one side or the other. So genetics-wise, 10% of Japanese patients have a first-degree relative with moya moya. So there's obviously a predilection there. I've mentioned various different Asian descents, but there are some chromosomal anomalies that I've seen. These are the ones that are there. I don't know, and maybe Dr. Burke can talk about that part of it. But I don't typically send for genetics on patients with moya moya unless I know, like this family I did. Okay, another family was the daughter-in-law of a scrub tech who was in Okinawa, so his wife came back with him and she bleeds, right? So there's a family there, so I went ahead and continued that, but it's not routine for me because it's not much we're going to do except for watch, right? But when we talk about twins, right? So twins typically have a 50-50, right? But it's very rare to have twins have both be affected. So if twins aren't affected, then is there something that's environmental, and you have to wonder about that. So, but there's a lot of room on the genetic side of things. This is what we usually tell patients, that the natural history, it depends on the etiology, which I already told you is we're still trying to kind of figure out. But typically there is some progression at one point. These patients, when you see them, you're following them for life. About 2/3 of the patients will have some sort of symptomatic progression over the first 5 years. The medical therapy, there's not a medical therapy we're targeting, so to say that it affects the progression is hard, right? I typically will tell patients, you do vessel health, right? You have vessel disease, and frankly, if the posterior circulation is not involved, take care of that, right? But the neurologic status at presentation is probably your best predictor. If they came in and they already had multiple strokes on both sides, and you're catching them at a very, very late stage, you're a little more worried about them than their first small TIA, right? So this is a typical picture of a patient with moyamoya, especially if they have one side, right? And we call that a watershed infarct. And it's a farming terminology, and I basically say you have two fields you're irrigating, and that's your brown grass. And everybody goes, oh, I get it. So, but that's what we're looking at there. It's a watershed infarct. So you're going to see that and say it's probably on the left side is where the problem is, right? I typically will do, just kind of looking at it from another angle, but MRI for looking at the infarct patterns. Do we see other things? Some sort of angiography. I tend to lean towards conventional angiography so we can better understand the movement of blood flow. And this again is what you'll start to see. This is just a kind of an example of this one's okay, but when you start seeing vessels creep over that far, this is about where your watershed is. You're kind of wondering, is something else going to be on the other side? Okay, this side here is already a little bit proliferative. Okay, but we're looking at all that, and sometimes you don't get that on CTA. They come to us with the CTAs because that's an easy thing to do, but the angiogram gives us a little bit more information about how blood moves, and that's what we get out of that. So these grades we use them more academically and then talk about grading skills, but some of the worst is ICA is completely occluded, and you're losing those moya vessels, okay? And I'll show you some examples of that. But a lot of what we're doing, and this is an area of research for me, is looking at the reserve. How are these patients doing, right, as the vessels go down? We know a lot of times as vessels go down, then the body, if it's healthy enough and patients are paying attention, can find a way to compensate. The initial compensation is by dilating those blood vessels, getting as wide open as you can to get the blood flow. But if patients are maximally dilated and then we challenge them, okay, they get dehydrated or they get overheated or they have a bleeding insult, blood pressure medication because the primary care is trying to treat the blood pressure, right? Then they may not be able to tolerate that stress. So one of the things that we do are different MR, CT, SPECT is older, but frankly approved more by insurance. But those different types of tests can look at blood flow when you're regular, and then blood flow, I say, when you're pissed off, right? That's your stress test. So it's your brain stress test. This is a cerebral blood flow test, just an example. And a lot of this is very qualitative. We can look at cerebral blood volume, and remember that person that you start seeing a hole here. Okay. And one of the things that's really interesting about this test, this is mean transit time, and we won't get into all the details, but mean transit time, it makes sense, right? How long does it take blood to get to the brain if one side is normal and the other side is impaired, right? Long, right? I mean, it's not rocket science. It's going to take a long time. Now, does it get there in time enough to not cause a symptom, right? Or on the same side where we're seeing strokes. So this mean transit time part for me is not as useful as what happens when we give patients things like Diamox is one that we use. It's a mountain sickness medication, right? A lot of people use it, but it dilates, and that's our stress. And if we see things drop, then we're concerned, right? So this is a test that we use called NOVA. It's a little bit more of a baseline test, but we can use this. I use this over time to see how blood flow is going through the vessels, okay? And then we can, so I don't have to keep doing angiograms. But this is just it's an MRI with something called phase contrast, so we can use that. Medical therapy generally is geared towards preventing thrombus, and I mean, we see all different types. Some people are on no meds when they get to us. Some people are on dual antiplatelets when they come to us. Some people are on Coumadin when they come. Some people are on aspirin when they come. My preference is aspirin. I can't jump up and down about dual antiplatelets, but anticoagulation in patients who are at a bleeding risk, I'm a little bit worried about that. And they're typically at higher risk later on, right? Because they've already got blood vessel problems now when they're early. So we kind of talk about that. One of the things that people get when I tell them to exercise and take care of those blood vessels is every inch of fat's a mile of blood vessels. Where would you rather that mile go, right? So when we talk about surgical therapy, kind of the whole point here is to develop a frontage road. I didn't know about frontage roads until I came to Texas, but it made sense. Okay, this is just, and I'll go through here just a little bit because we're not talking about as much of the surgery. Because I thought I had one here, I don't. Sorry, but this, direct bypass is probably the more common thing in adults with blood vessels greater than 1.5 millimeters. That's what we do. Okay, that's a direct taking the temporal artery and tying it into the MCA, and we tend to do a bit of that at our place when it's necessary, right? Because those timings are off. There are some times when we can't do that because the blood vessels are too small, and we do something called a There you can see why it's EDAMS and EMAMS, because encephaloduromyostangiosis, and we're bringing the blood vessels closer to the brain, and we're opening the dura and the pia to get more opportunity for those collateralizations that they're already trying to make to occur. Up until recently, that was more of a kid thing because the blood vessels were smaller, right? But now we're seeing more information about some patients, adult patients, who actually do well. We have a back and forth going with Hopkins right now. For interesting, in Hopkins, all they do is indirects, right? Whereas we tend to do a lot more directs. I won't tell you who's winning, but but I think it's helpful. I think the most important part for this group when we talk, we're not getting into the surgery as much, is recognizing it. Okay, and treating it, and then what do we talk about with the EVMs? The same thing, getting people into a place where everyone's on the same page, taking care of the patient, right? But if we don't recognize it first, all right, new hypertension, headaches that we can't control, ischemic episodes that we can't explain. And then really, otherwise you talk about these patients as you would with patients with stroke. Right, maintain your hydration. Maintain your vessel health. Anything good for the heart's good for the brain. Okay, that's what we try to get into. A couple of things that we coordinate a lot is they don't need to have a normal blood pressure up front, right? Because that's a lot of times where the strokes are coming from. The primaries throw in blood pressure medications at them, but they're not 115 over 75 people, right? They're doing it for a reason. So that's something that we want to avoid. I usually follow these patients for a long period of time, so we can make sure that we're not seeing the other side. The bilateral progression is something that we still watch. I think that's a lower incidence than in the Asian population, like we talked about. Okay, because I just don't see it as much in the patient group that I take care of. But I know we started a little bit late, so I tried to move forward, and I'm happy to answer any questions about this complex patient population, but it's an interesting one to take care of. Questions? Thank you.
Dr. Welch, what about, you said about staying in touch with them for a long time. What's a typical long time you stay in touch, follow?
Forever. I mean, honestly, and we can both go on. I think it's probably one of the hardest things for our clinics to handle is once you get a decent number of these patients that you're following up with, how long you follow. Now, I have patients that I saw 20 years ago they're kind of like, yeah, I get it. I'm doing it. They've done what they're supposed to do, and they will be in, over time with their MRIs and the NOVAs that we check. Whereas there are other patients who have just not quite gotten the rhythm yet. But when we enter and we start talking about it, we're talking about them for their life, right? After the problem is after they're, in their late 50s, 60s, then they start getting into other vessel disease, right? But it sounds kind of morbid, but I haven't met a brand new Moya Moya patient at 50, right? There's usually something else going on. So, yeah.
Well, and one of your points in there about medical history, not into progression or for the progression of Moya Moya. What about music and that therapy of that music therapy to make an impact? What's your take?
I have never had that one before, but I think I would put that more in the just general health standpoint, right? And if you talk about stroke recovery, okay, but most if you're seeing the patients early, they're not having massive strokes. The ones that bleed, even they're having small strokes and they're picking stuff off, right? So if I go towards general health and I'm a music person, then I think it's important, right? So,
right.
Yeah.
And what I was thinking too, because in the Moya Moya, they just expand and go out. How music has such incredible, intricate of calming.
Sure.
There's such a relaxing, just automatically.
Well, it goes. I mean, it's similar to what we talked about in the prior lectures. The psychology of this is you've just taken. I've this young girl. I've taken her, and I'm gonna have to. She's just finishing college with this diagnosis, and she's looking forward to future, right? But now she also knows she has to pay attention to this chronic disease, right? So yeah, no question. Any way to kind of handle that psychologically, I think it's a big deal. So. All right. Thank you.